What would drive an experienced emergency room nurse to question everything she thought she knew about medicine, life, and death itself? In today's story, you'll meet Sarah Chen, a veteran ER nurse with 12 years of experience who encountered something that defied every medical textbook she'd ever studied. This is the case that made her reconsider her entire career. And after hearing what happened that October night, you might understand why. But before we dive into this impossible case, make sure to subscribe to help us reach our next milestone. Drop a comment below telling us where you're watching from, and stick around until the end because this story will challenge everything you think you know about emergency medicine. There are moments in healthcare when you realize that all your training, all your experience, and all your scientific understanding barely scratches the surface of what's truly possible in this world. I've carried one such moment with me for 18 months now, and only recently have I found the courage to share what really happened that night at Metropolitan General Hospital. My name is Sarah Chen, and I've been a registered nurse in emergency medicine for over a decade. I've seen car accidents that shouldn't have been survivable, heart attacks in 20-year-olds, and medical mysteries that stumped entire teams of specialists. I thought I had witnessed every possible variation of human trauma and recovery. I prided myself on staying calm under pressure, thinking rationally in chaos, and never letting emotion cloud my medical judgment. That confidence was shattered on October 14th, during what started as an ordinary night shift in one of the busiest emergency departments in the city. Metropolitan General Hospital serves a population of nearly 2 million people across the greater downtown area. Our emergency department sees everything from minor cuts requiring stitches to multi-trauma cases from major accidents. As a senior nurse, I was responsible for triaging incoming patients, coordinating with physicians, and managing the constant flow of medical emergencies that define urban health care. The night that changed everything began like countless others. I arrived at 6:30 p.m. for my 7 p.m. to 7 a.m. shift, grabbing coffee and reviewing the day shift's patient census with my colleague Marcus Rodriguez, who was preparing to head home. The department was moderately busy with the usual mix of cases: chest pain evaluations, minor injuries, and elderly patients with various medical complaints. Dr. Amanda Foster was the attending physician that evening, a brilliant emergency medicine specialist with 15 years of experience. Working alongside her were Dr. James Park, a third-year resident, and Lessa Thompson, another experienced nurse who had been with Metropolitan General for almost as long as I had. It was a solid team that had handled countless emergencies together. The first unusual sign came at 9:47 p.m., when the ambulance radio crackled to life with a report that immediately caught everyone's attention. The paramedics were bringing in a 43-year-old male who had been found unconscious in his apartment by concerned neighbors. What made the case interesting wasn't the unconsciousness itself, but the circumstances surrounding his condition. The patient, whom I'll call Michael Torres to protect his privacy, had been discovered lying peacefully on his living room floor with no signs of trauma, no evidence of drug use, and no obvious medical emergency. His vital signs were stable, his breathing was regular, and there were no visible injuries or signs of distress. Yet he was completely unresponsive to all stimuli, including painful procedures that should have awakened even deeply unconscious patients. When the ambulance arrived, I was assigned as Michael's primary nurse. As the paramedics wheeled him into Trauma Bay 3, I got my first look at what would become the most perplexing case of my career. Michael appeared to be sleeping peacefully, with normal color in his skin, regular breathing patterns, and stable, vital signs. His blood pressure was 118/76, his heart rate was 72 beats per minute, and his oxygen saturation was 98% on room air. By every measurable standard, he appeared to be a healthy man taking a nap. But Michael wasn't sleeping. He was completely unresponsive to verbal commands, physical stimulation, and even painful procedures. Dr. Foster performed a thorough neurological examination, checking his pupils, reflexes, and responses to various stimuli. His pupils were equal and reactive to light. His reflexes were normal, and his muscle tone was appropriate. Yet he showed no response to his name, to loud noises, or to physical contact. "This is unusual," Dr. Foster commented as she completed her initial assessment. "His neurological exam is essentially normal, but he's showing no signs of consciousness. Let's get a full workup, including CT scan of his head, comprehensive blood work, and toxicology screening." I drew blood samples and prepared Michael for transport to radiology, while Dr. Park began documenting the case. As I worked with Michael, I noticed something that struck me as odd. While he was completely unresponsive to external stimuli, his positioning seemed almost intentional. He lay with his arms folded across his chest, his legs straight, and his head positioned perfectly straight on the pillow. It was as if he had carefully arranged himself before losing consciousness. "Lisa, have you ever seen positioning like this in an unconscious patient?" I asked my colleague as we waited for the CT results. "Not really," she replied, studying Michael's appearance. "Most unconscious patients have some degree of muscle relaxation that causes them to settle into more natural positions. He looks like he's been posed." The CT scan results came back completely normal. No signs of stroke, bleeding, swelling, or any other brain abnormalities that might explain his condition. His blood work was equally puzzling. All values were within normal ranges, with no signs of infection, metabolic disorders, or organ dysfunction. The toxicology screen was negative for drugs, alcohol, and common poisons. Dr. Foster reviewed the results with growing puzzlement. "Medically speaking, there's no reason for this patient to be unconscious. Everything we can measure looks completely normal." As the night progressed, we continued monitoring Michael while running additional tests. We performed an electroencephalogram to measure his brain activity, expecting to find patterns consistent with coma or other altered states of consciousness. Instead, the EEG showed something that left our neurologist consultant speechless. Michael's brain waves showed patterns consistent with deep, restful sleep. Not the abnormal patterns associated with coma, not the chaotic activity seen in seizure disorders, but the regular organized waves of someone enjoying peaceful slumber. Yet he remained completely unresponsive to all attempts to wake him. "I've never seen anything like this," Dr. Foster admitted as we stood outside Trauma Bay 3 at 2:30 a.m. "His brain is functioning normally, his body is healthy, but he's locked in some kind of sleep state that we can't break." It was then that we noticed something that would make this case even more mystifying. Michael's position had changed. He was no longer lying with his arms folded across his chest, but had shifted to his side with one arm under his head, as if adjusting his position for comfort during sleep. Yet our continuous monitoring showed no signs of movement, no periods of wakefulness, and no changes in his unresponsive state. "That's impossible," Lisa whispered as we compared his current position to the photographs we had taken during his initial assessment. "We've been watching him continuously. There's no way he could have moved without us noticing." I checked the cardiac monitor strips and nursing notes. Throughout the entire shift, Every 15-minute assessment had documented Michael as lying motionless and unresponsive. Yet somehow, he had repositioned himself without anyone observing the change. Dr. Foster called in Dr. Rebecca Martinez, our most experienced neurologist, for an emergency consultation. Dr. Martinez had seen thousands of cases of altered consciousness throughout her 20-year career. But after examining Michael, she was equally baffled by his condition. I've consulted on cases of catatonia, conversion disorders, and rare neurological conditions, Dr. Martinez said after completing her examination, but this patient defies classification. His neurological function appears intact, yet he remains in what I can only describe as an impenetrable sleep state. By 4 a.m., we had exhausted our standard diagnostic protocols. Michael's condition remained unchanged, his vital signs stable, and his mysterious repositioning continued. Every hour, we would find him in a slightly different position, always appearing more comfortable, as if he was actively adjusting himself during sleep. Yet our constant monitoring revealed no periods of movement or consciousness. That's when Dr. Foster made a decision that would change everything about this case. "I want to try something unconventional," she announced, pulling me aside. "What if we approach this differently? Instead of trying to wake him up, what if we try to communicate with him while he's in this state?" The idea seemed medically questionable, but given our lack of progress with traditional approaches, Dr. Foster decided to attempt direct communication. She positioned herself close to Michael's bed and began speaking to him in a calm, clear voice. "Michael, if you can hear me, I need you to try to respond in any way possible. Move a finger, change your breathing, anything to let us know you're aware." For several minutes, nothing happened. Michael continued his peaceful, unresponsive state while we watched his monitors for any subtle changes. Then, at exactly 4:23 a.m., something extraordinary occurred. Michael's heart rate, which had remained steady at 72 beats per minute for hours, suddenly increased to 85 beats per minute. It wasn't a dangerous elevation, but it was a clear, measurable response to Dr. Foster's request for communication. "Did you see that?" I asked, pointing to the cardiac monitor. "His heart rate just increased right after you asked him to respond." Dr. Foster tried again. "Michael, if that was intentional, can you make your heart rate change again?" Within 30 seconds, Michael's heart rate dropped back to 72 beats per minute, then increased again to 84, then returned to baseline. The pattern was too precise and too well-timed to be coincidental. "He's responding," Dr. Martinez said with amazement. "He's conscious and aware, but he's communicating through physiological changes rather than physical movement." Over the next hour, we developed a rudimentary communication system with Michael. 1 heartbeat elevation meant yes, no change meant no. Using this method, we discovered information that challenged everything we thought we understood about consciousness and medical states. Michael was fully aware of his surroundings, could hear our conversations, and understood everything happening around him. He confirmed that he was not in pain, was not frightened, and was not trying to wake up. Most remarkably, when Dr. Foster asked if he was choosing to remain in this state, his heart rate increased dramatically, indicating a strong yes response. "Michael, are you in control of your condition?" Dr. Foster asked. His heart rate jumped to 95 beats per minute and stayed elevated for a full minute before returning to normal. It was the strongest response we had seen all night. The implications were staggering. Michael wasn't the victim of some mysterious medical condition. He was somehow consciously maintaining this state, controlling his level of consciousness in a way that medical science couldn't explain. "This is unprecedented," Dr. Martinez whispered as we reviewed the cardiac monitor strips documenting our communication session. He's demonstrating voluntary control over his state of consciousness while appearing completely unconscious to external observation. As dawn approached, we faced an impossible decision. Michael was medically stable, showed no signs of distress, and appeared to be in his current state by choice. Yet he remained completely unresponsive to traditional medical intervention and showed no signs of wanting to return to normal consciousness. Dr. Foster attempted one more communication session before the day shift arrived. "Michael, do you want to return to normal consciousness? Do you want to wake up?" For the first time all night, Michael's heart rate dropped significantly below baseline, settling at 58 beats per minute. It was a clear, emphatic no. "Are you safe in this state? Are you comfortable?" His heart rate returned to 72 and remained steady, indicating yes. "Should we continue medical intervention, or should we allow you to remain as you are?" The response was immediate and decisive. Michael's heart rate dropped to 55 beats per minute and stayed there for several minutes. He was clearly communicating that he wanted to be left alone in his chosen state. At 6:45 a.m., as I prepared to give report to the incoming day shift, I realized that we had encountered something that existed outside the boundaries of conventional medicine. Michael Torres had somehow achieved voluntary control over his state of consciousness, entering a condition that appeared unconscious to outside observers, while maintaining full awareness and the ability to communicate through physiological responses. The day shift nurses and physicians were skeptical until they witnessed Michael's communication abilities for themselves. Dr. Sarah Kim, the incoming attending physician, spent an hour attempting to understand Michael's condition before admitting that it defied medical explanation. "I've never encountered anything like this in 20 years of emergency medicine," Dr. Kim confided to me before I left that morning. "We're going to have to develop entirely new protocols for managing a patient who chooses to remain in an altered state of consciousness." As I drove home that morning, I couldn't stop thinking about the implications of what we had witnessed. If Michael could voluntarily control his state of consciousness to this degree, what did that mean about the nature of awareness, medical intervention, and patient autonomy? How many other cases of unexplained unconsciousness might actually involve patients who were choosing their condition? Most disturbing was the question of why Michael had chosen this state. What could drive someone to voluntarily enter a condition that appeared unconscious to the outside world while maintaining full internal awareness? The answers to those questions would come 3 days later when Michael's sister, Elena Torres, arrived at the hospital after being notified by our social services department. Elena provided background information that cast Michael's condition in an entirely different and more troubling light. Michael has been struggling with severe depression and anxiety for the past 2 years, Elena explained to Dr. Kim and me during our consultation. He lost his wife in a car accident, and he's been unable to cope with daily life. He's tried therapy, medication, everything the doctors recommended, but nothing helped. Elena revealed that Michael had been researching meditation, consciousness studies, and what he called escape methods for months before his hospitalization. He had become fascinated with accounts of people who claimed to achieve altered states of consciousness through various techniques. He told me last month that he had found a way to step outside of his pain. Elena said, tears forming in her eyes. He said he could go somewhere in his mind where the grief couldn't reach him. I thought he was just talking about meditation or therapy techniques. This information transformed our understanding of Michael's condition. He hadn't fallen into this state accidentally, or due to some mysterious medical condition, he had somehow trained himself to achieve voluntary unconsciousness as a way of escaping psychological pain that had become unbearable. Dr. Kim immediately consulted with our psychiatric department, bringing in Dr. Robert Chen, our chief psychiatrist, to evaluate the situation. Dr. Chen had extensive experience with catatonia, dissociative disorders, and various psychiatric conditions that could affect consciousness, but he was as puzzled by Michael's case as the rest of us. From a psychiatric standpoint, this doesn't fit any known diagnostic category, Dr. Chen explained after reviewing Michael's case. Catatonic patients typically show muscle rigidity or other physical symptoms. Dissociative disorders usually involve periods of normal consciousness, alternating with altered states. Michael appears to have achieved sustained voluntary unconsciousness while maintaining physiological stability. Over the following days, our communication sessions with Michael became more sophisticated. We discovered that he could control not only his heart rate, but also his blood pressure and respiratory patterns to communicate complex responses. Using combinations of these physiological changes, we developed a more nuanced communication system. Through this method, we learned that Michael was experiencing his unconscious state as a form of peaceful existence separate from his physical body and emotional pain. He described it, through our physiological communication system, as floating in a space where memories of his wife's death couldn't reach him. When Dr. Chen asked if Michael understood the medical and legal implications of his condition, the response was immediate and clear. Michael's vital signs indicated that he was fully aware that his state was unprecedented, potentially dangerous, and raised serious questions about patient autonomy and medical decision-making. "Michael, do you understand that we can't discharge you in this condition?" Dr. Chen asked during one communication session. Michael's heart rate elevated significantly, indicating yes. "Do you understand that your family is worried about you?" Again, a clear yes response through cardiac changes. "Are you willing to work with us to return to normal consciousness?" For the first time since his admission, Michael's response was ambiguous. His heart rate fluctuated unpredictably for several minutes, suggesting internal conflict about the question. Dr. Foster, who had remained involved in Michael's care despite the case being transferred to internal medicine, attempted a different approach. "Michael, what would it take for you to feel safe returning to normal consciousness?" The response was unlike anything we had seen. Michael's heart rate began following a specific pattern, increasing and decreasing in what appeared to be a deliberate rhythm. After several minutes of recording these patterns, Dr. Chen realized that Michael was communicating in a form of physiological Morse code. Decoding his cardiac patterns revealed a message that left the entire medical team stunned. Michael was spelling out words using variations in heart rate duration and intensity. His message was simple but profound. "Need to know she forgives me." Elena was called back to the hospital to help us understand what Michael meant. Through tears, she revealed the complete story behind her brother's condition. "Michael was driving when the accident happened," Elena said quietly. "A drunk driver ran a red light and hit them. But Michael has convinced himself that if he had taken a different route, or left 5 minutes earlier, or made different decisions that day, his wife would still be alive. He's been torturing himself with guilt over circumstances that were completely out of his control." This revelation provided the key to understanding Michael's psychological state. His voluntary unconsciousness wasn't just an escape from grief, but from overwhelming guilt that had made normal life impossible for him. He had literally trained himself to step outside of conscious existence, rather than face the self-blame that consumed his waking hours. Dr. Chen worked with Elena to develop a therapeutic approach that could address Michael's guilt while he remained in his altered state. Using our physiological communication system, Dr. Chen began conducting therapy sessions with an unconscious patient, a technique that had never been attempted in psychiatric medicine. Michael, your wife's death was caused by a drunk driver who made the choice to get behind the wheel. Dr. Chen said, during one session, you were the victim of someone else's dangerous decision. Michael's physiological responses indicated that he intellectually understood this fact, but his cardiac patterns also revealed continued emotional resistance to accepting it. The breakthrough came when Elena brought a recording of her brother's wife, Maria, talking about how much she loved Michael and how happy their marriage had made her. The recording had been made just weeks before the accident for their anniversary. As Elena played Maria's voice expressing her love and gratitude for their life together, Michael's vital signs showed dramatic changes. His heart rate became erratic, his blood pressure fluctuated wildly, and for the first time since his admission, he showed signs of physical distress. Michael, Maria loved you completely, Elena said as the recording played. She would never want you to blame yourself for what happened. She would want you to live and be happy. Suddenly, at 2:17 p.m., on his 7th day in the hospital, Michael's eyes opened. He took a deep breath, looked around the room with confusion, and spoke his first words since his admission. Elena, where am I? What happened? His return to consciousness was as medically inexplicable as his voluntary unconsciousness had been. Within minutes, he was fully alert, oriented, and showing no residual effects from his week-long altered state. His neurological function was completely normal, his vital signs stable, and his physical condition unchanged. But Michael's emotional state was dramatically different. The overwhelming guilt and despair that had driven him to seek unconscious escape had been replaced by what he described as a profound sense of peace and acceptance. I heard everything while I was away, Michael explained to Dr. Chen during his psychiatric evaluation. I could hear all of you talking. I understood what was happening. But I was somewhere else, emotionally, somewhere safe. When I heard Maria's voice, I realized I was hiding from her memory instead of honoring it. Dr. Chen documented Michael's recovery as the most unusual psychiatric case he had encountered. Michael had essentially created his own therapeutic environment within an altered state of consciousness, processing his grief and guilt while maintaining physiological stability and the ability to communicate with medical staff. From a psychiatric standpoint, Michael developed a dissociative state that served as a protective mechanism while allowing continued psychological processing. Dr. Chen explained to our medical team. He maintained enough connection to external reality to ensure his physical safety, while creating the emotional distance necessary to work through traumatic guilt. Michael was discharged after 2 additional days of observation and follow-up psychiatric evaluation. His recovery was complete, and he showed no signs of wanting to return to his voluntary unconscious state. He began grief counseling and support group therapy, approaching his healing process with the same determination he had shown in creating his escape mechanism. 3 months later, Michael returned to the hospital to thank the staff who had cared for him during his unprecedented medical experience. He appeared healthy, engaged, and emotionally stable. He had returned to work, reconnected with family and friends, and was actively participating in a support group for people who had lost spouses in accidents. I know what I did seems impossible, Michael told me during his visit. I'm not even sure how I learned to control my consciousness like that, but I needed to find a way to step outside my pain long enough to process it without being destroyed by it. Your team helped me do that safely. Michael's case was written up in several medical journals as the first documented instance of voluntary, sustained unconsciousness maintained through conscious physiological control. Dr. Chen presented the case at psychiatric conferences, and Dr. Foster published findings about the communication techniques we had developed. But for me, Michael's case raised questions that went far beyond medical documentation. If one person could achieve such precise control over consciousness and physiological responses, what other capabilities might exist within human awareness that we simply haven't discovered or acknowledged? The case also highlighted the limitations of traditional medical approaches to treating psychological trauma. Michael had found a solution that no medication, therapy, or medical intervention had been able to provide. His voluntary unconsciousness had served as both a protective mechanism and a therapeutic environment that allowed healing to occur in ways that conventional treatment couldn't achieve. Most significantly, Michael's experience challenged fundamental assumptions about consciousness, patient autonomy, and the relationship between mind and body in medical care. He had demonstrated that patients might have capabilities for self-regulation and healing that extend far beyond what medical science typically recognizes or utilizes. As I reflected on those 7 days of caring for a consciously unconscious patient, I realized that Michael Torres had taught me more about the potential of human consciousness than 12 years of emergency medicine training had provided. His case reminded me that despite all our medical knowledge and technological capabilities, we still have much to learn about the true nature of human awareness and the healing process. Looking back on Michael's case, I began to notice patterns in other patients that I had previously overlooked. The elderly woman who seemed to respond to conversations even while heavily sedated, the comatose teenager whose vital signs fluctuated in ways that correlated with family visits, the stroke patient who showed awareness through subtle changes in breathing patterns when specific topics were discussed. Had I been missing signs of consciousness and communication in patients throughout my entire career? Michael's case suggested that the line between conscious and unconscious states might be far more blurred than medical training had taught me. Perhaps there were patients experiencing awareness in ways that our standard assessments simply couldn't detect or measure. I started documenting unusual physiological responses in patients with altered consciousness, looking for patterns that might indicate hidden awareness. Over the following months, I identified at least 6 cases where patients showed responses that suggested possible conscious communication through physiological changes. None were as dramatic or sustained as Michael's case, but the patterns were there once I knew what to look for. Dr. Foster became equally interested in exploring these possibilities. She began researching consciousness studies, meditation practices, and alternative approaches to patient communication. Together, we developed informal protocols for attempting physiological communication with unresponsive patients, always with family consent and psychiatric consultation. The results were limited but intriguing. We discovered that some patients in vegetative states showed consistent heart rate responses to specific questions or stimuli. Others demonstrated breathing pattern changes that seemed to correlate with emotional content in conversations. While none achieved Michael's level of sustained communication, these findings suggested that consciousness might exist in forms that traditional medical assessment couldn't recognize. However, our explorations also revealed the darker implications of Michael's case. If patients could maintain hidden awareness during medical procedures, what were the ethical implications for surgical intervention, life support decisions, and end-of-life care? The possibility that some supposedly unconscious patients might be experiencing full awareness while appearing completely unresponsive was deeply disturbing. I began having nightmares about patients I had cared for over the years, wondering if any had been consciously aware while appearing unconscious. Had I performed procedures on patients who could feel everything but couldn't communicate their distress? Had families made decisions about life support for loved ones who were actually conscious and aware but unable to demonstrate it? These questions became more than academic concerns when, 6 months after Michael's discharge, we encountered another case that seemed to involve voluntary altered consciousness. A 38-year-old teacher named Jennifer Walsh was brought to our emergency department after collapsing at work. Like Michael, she appeared to be sleeping peacefully but was completely unresponsive to all stimuli. Her vital signs were stable, her neurological exam was normal, and all diagnostic tests came back within normal ranges. Given our experience with Michael, Dr. Foster immediately attempted physiological communication protocols. Within an hour, we had established that Jennifer was fully aware and had voluntarily entered her unconscious state. But Jennifer's case was different from Michael's in troubling ways. While Michael had used his altered state to process grief and trauma, Jennifer appeared to be using unconsciousness as an escape from an abusive marriage. Through our communication system, we learned that she had discovered she could enter this state whenever her husband became violent, effectively removing herself from situations where she felt helpless and endangered. The ethical implications were staggering. Jennifer was using voluntary unconsciousness as a survival mechanism in a dangerous domestic situation. While her technique protected her from immediate harm, it also prevented her from taking action to permanently escape her abuser or seek help for her situation. Dr. Chen worked with social services and domestic violence counselors to address Jennifer's case. The challenge was enormous. How do you provide crisis intervention and safety planning for someone who communicates only through physiological responses while maintaining apparent unconsciousness? Over several days, we developed a comprehensive approach that involved Jennifer's sister, domestic violence advocates, and law enforcement. Through our communication system, Jennifer was able to provide information about her husband's patterns of violence, her fears about leaving, and her concerns for her safety if she returned home. The case highlighted both the remarkable adaptive capabilities of human consciousness and the devastating circumstances that might drive someone to develop such extreme coping mechanisms. Jennifer had essentially taught herself to disappear from her own life whenever it became unbearable, but this escape mechanism also prevented her from accessing the resources and support she needed to create lasting change. After a week of careful planning and coordination with multiple agencies, Jennifer was presented with a comprehensive safety plan that included immediate protection, legal advocacy, and long-term housing assistance. Only when she felt assured of her safety did she choose to return to normal consciousness and begin the process of rebuilding her life away from her abuser. Jennifer's case was followed by 2 more instances of voluntary altered consciousness over the next year. Each patient had developed this capability as a response to overwhelming psychological trauma or unbearable life circumstances. Each case required innovative approaches to communication, assessment, and treatment that challenged traditional medical protocols. The pattern that emerged was both fascinating and heartbreaking. Voluntary unconsciousness seemed to represent an extreme form of dissociation that some individuals developed when normal coping mechanisms proved inadequate. These patients had essentially created their own psychological escape hatches, allowing them to step outside of consciousness when reality became unendurable. But the cases also revealed the remarkable plasticity and adaptability of human consciousness. These patients had achieved precise control over their neurological states without any formal training or medical intervention. They had discovered techniques for consciousness manipulation that academic researchers were only beginning to understand. Michael's case changed everything for me as a healthcare professional. It shattered my understanding of consciousness, patient care, and the incredible capabilities hidden within the human mind. That October night taught me that medicine still has profound mysteries to uncover, and that sometimes the most impossible cases reveal the most important truths about human resilience and healing. If you've encountered medical mysteries that defied explanation, share your stories in the comments below. And if this case left you questioning what else might be possible in healthcare, make sure to subscribe for more stories that challenge everything we think we know about medicine.